Good evening, doctors and all participants. I am Dr. Rizin Kusub, the Secretary of APPS. Welcome to our free live streaming webinar brought to you by Association of Private Practitioner Sabah APPS. If you have questions, please write them down on the comment section in the YouTube platform and they will be addressed by the speaker at the end of the session. Our speaker this evening is Dr. Arfian Ibrahim. Dr. Arfian Ibrahim is currently the consultant physician and pulmonologist in Gleneagles Hospital, Kota Kinabalu. He graduated from University of Wales, UK in 2000 and had his MRCP and subsequently became respiratory physician in 2010. He started working as a house officer in UK and had been in various hospitals in UK, Australia, and Malaysia, including in Sabah, Queen Elizabeth Hospital, and Tawau Hospital, and now in Gleneagles Hospital, Kota Kinabalu. He is also a certified medical impairment assessor of NIOSH and has been involved in many academic publications in the past. The topic for this evening is managing URTI in primary care. Ladies and gentlemen, Dr. Arfian Ibrahim.
Hi, thanks a lot, Dr. Rizin, for that kind introduction. First of all, I'd like to thank the APPS for inviting me to give this talk. They've given me quite a very big task to try and talk about URTI in primary care. So as you all know, the upper airway respiratory tract includes those that starts all the way from your nose down to your nasal passages, including your paranasal sinuses, the pharynx, and basically the portion of the larynx just above your vocal cords. The definition of upper respiratory tract infection is basically a self-limited irritation. So the main key points to remember is that it's a self-limited illness. It involves an irritation and swelling of your upper airways. And it's normally associated with cough. But again, most importantly, there should be no signs of pneumonia. Now, the signs of pneumonia can be either from your clinical examination. When you examine the patient, you look for consolidation changes, or from your x-ray if you do have the facility in your center. Next slide. Oops, sorry. Right, sorry. Okay, thanks. So the main thing is when you do see a patient who comes into your clinic, and you want to decide whether does this patient actually do have a URTI or does he have something else. And there are a few risk factors that you can look for in the initial consultation when you see a patient. And basically, these are people who known to have close contact with children, so patients who either owns a daycare or works in the daycare and the school. Patient with chronic disorder. And we're looking at patient with asthma or patient with allergic rhinitis. These are the two types of people that if they do have it, they're more likely to develop an upper respiratory tract infection. If they're smoking is a very common risk factor for URTI. So you do have a smoker coming into your clinic and you think they may have a URTI and they have smoking as a history, think about URTI. Think about immunocompromised individual. We don't see that much cystic fibrosis here, but we do have a population of HIV, especially now with the use of corticosteroids, especially with the COVID pandemic. I think you will see that a lot of patients post-COVID who are hospitalized in the more severe categories are being discharged with corticosteroids for approximately about 6 weeks. So these are the patients who may develop a URTI and higher risk. Transplantation and post-splenectomy patients are other patients at high risk of developing URTI. Other things that can predispose you to a URTI is basically you have anatomical anomalies, facial dysmorphic changes, or you have nasal polyposis. All these are the risk factors. So these are the initial screening when you first see your patient in the clinic and you have a chat with them for a few minutes. Okay. Now, to cover URTI in such a short period will take a longer time. So what I've done is basically I'm just going to talk about 3 major areas, which I think what you're going to be seeing mostly in your private center, and basically one which is acute cough, 2, sore throat, and 3 is either rhinosinusitis or also known as sinusitis. So we'll go through each of them one by one, and we'll quickly try and make it short and simple so everyone can understand it very well. Now, in acute cough, we have to differentiate that this patient is actually having an acute cough rather than a prolonged or a chronic cough. So basically, if a patient comes in to you and they say that they have cough, ask about the duration. If it's less than 3 weeks, you're dealing with acute cough. On average, a patient who comes to you will have a duration of 18 days. And sometimes, some guidelines will say that acute cough can last all the way up to 4 weeks. Right? Most commonly, patients with acute cough, they will be due to either a viral infection. And most common you're going to see in private centers or in any of your centers is basically a cold, common cold or flu. Obviously, with the current pandemic, if anyone comes in with a cough, the first thing we'll think about is COVID first before we think of anything else. We do think about pneumonia as well. Patients with chronic lung disease, patients with asthma or COPD, they may come in with an acute cough where it is an exacerbation. Bronchiectasis may also come in with exacerbations, but then they will also have a history of chronic cough on top of the acute symptoms. And the last few infective causes of cough, which is the viral-induced wheeze, your bronchiolitis, croup, and whooping cough, are more commonly seen in the pediatric group. But don't forget as well, acute cough can also present in non-infective causes, things like lung cancer or foreign body. Interstitial lung disease. One of the first few symptoms of ILD is basically cough before they develop exertional dyspnea. Pneumothorax, pulmonary embolus, heart failure, and the list goes on. Look for certain medicines as well. As we all know, angiotensin converting enzyme inhibitor can also cause an acute cough. Think about upper airway cough syndrome as well, especially your postnasal drip. Majority of my cough patients that do walk into my clinic actually have a lot of them are postnasal drip syndromes. And also think about reflux that can cause cough. So I'm going to go into common cold because that's one of the biggest common thing that you're going to see in your practice. And basically, it's a common virus, which is a rhinovirus. Other things that can cause it are like your influenza virus, your adenovirus, your enterovirus, and your RSV. About 15% of these cases will be bacterial, and if it's bacteria, most commonly it will be a strep pyogenes. And again, the organism is acquired by inhalation of infected droplets. So almost the same as like COVID as well. Okay, but just if you do realize that in about a year, sometimes you do have patients who keep coming on to your clinic. They'll come about 2 to 3 times a year with common cold, and it's very common. And again, common cold is a clinical diagnosis. You don't need to do diagnosis testing. It's not really necessary, and you can make a diagnosis and start treatment immediately. Okay. Now, what I like to do in my clinic when somebody comes in with cough is actually to try and measure the cough. Now, obviously, a patient, if they have a cough which is not disturbing them, they're not going to come and see you. You're going to go and see to the nearest pharmacy, they're going to buy something over the counter, they're going to take it and try and get it better. When it doesn't get better or it interferes with their daily lives, interferes with the sleep, then they're going to come and see you. Of course, with the pandemic as well, the moment you have the slightest cough, the first thing you think is, do I have COVID? And they'll come and see you as well. So things have changed slightly over the years, especially with the COVID pandemic. But once you've ruled out COVID, so basically what I do in my clinic is basically I use 2 levels of where I gauge how bad the cough is. One is you could use a visual analog score. This is very simple. It's a 10 centimeter scale between 0, which is no cough, to 10, which is the worst cough. And you basically mark them at every 1 centimeter. And you ask the patient to put a point there where they think the cough is affecting them, or how bad their cough is. And then you can see them later on in follow-up and ask them to point again, how is it after you started treatment. So the minimal important difference in between the first scale and the second scale when you see them again in review is about 2 centimeter, right? Now another thing that you could use is a Leicester cough questionnaire. This is a little bit more tedious because it involves 19 questions which the patient has to answer, but it's a more complete and more objective measurements which actually measures your physical, psychological, and social impact of the cough. Now, if you do have time and you think that you like to go into it, I totally encourage you to do it. And again, the MID for in acute cough is actually 2 points, right? So this is from the journal in Journal Thoracic Disease. So once you quantify that someone has a cough and you say yes, it is definitely affecting the patient, and you objectively have quantified how much it's affecting the patient, you can start some treatment. And the majority, the goal, the treatment of common cough is basically symptom relief. There's nothing else. Most commonly, the recommendation is to use an H1 receptor antagonist. So these are all your antihistamines like your Zytrax, cetirizines, your loratadine, desloratadine. Okay, but evidence shows that it only offers a modest reduction to the symptoms. And we're looking at your rhinorrhea and your sneezing. And it's most effective if they do come into you in the first 2 days of cough, of the cold symptoms, sorry. Topical and oral nasal decongestant. Your topical oxymetazoline and your nasal oxynase, your oral pseudoephedrine, they have moderate benefit in the adults in reducing airway resistance. So basically, the topical and oral nasal decongestants are mostly for the nasal symptoms. The patients are going to come to you complaining of shortness of breath. And I do get patients who do come to my clinic as well with common cold who actually complain. The main complaint is not cold, the cough, it's actually that they find that they can't breathe. And when you carefully examine them, it's actually a nasal airway obstruction due to common cold. There's a lack of convincing evidence to support the use of dextromethorphan for acute cough. So if you're going to use anything cough syrup for acute cough, use more of opiate-based, codeine-based, which is more evidence for it. And just to quickly say that the complications of upper respiratory tract infections are relatively rare, except for influenza. As we all know, influenza has got can have a co-added infection with Staph aureus, which can be very fatal. Right? But again, vaccination is the most effective method of preventing these influenza-like illnesses. So I'm just basically then we've looked at common cold, and now we're going to try and differentiate: are we dealing with a common cold or are we dealing with a flu? There's a few signs and symptoms. This is from the CDC basically, and we're looking at a few things. So we're just going to quickly go through them. We're looking at symptom onset. So you can see the flu is very abrupt. So you're looking at about 48 hours time frame when you develop symptoms. Fever is very more common in flu. Aches and chills, fatigues as well. Sneezing is more common in cold. Chest discomfort is more common in flu. And then basically nasal symptoms, your stuffy nose, your sore throat are more common in cold, and headache is more common in flu. Now this is quite a long list to remember. How I find it easy to remember is that to divide it into more general terms. Basically, when you have a cold, you're looking at symptoms that affect predominantly localized areas in your upper respiratory tract. So you're basically your nasal symptoms, your sore throat, your sneezing, right? So if you have a flu, it's more of a systemic symptom. So you're looking at fever, your aches, your chills, your headaches, your chest discomfort, your cough. So these are more in the general terms of a systemic type of symptoms. So that's how I remember between cough and cold. Cold and flu. All right. So the second part that we're going to look at through is sore throat. So you got somebody who's coming to you with common cold, then they may come with you with sore throat as well. Acute sore throat may include pharyngitis and tonsillitis, and majority of it again is self-limiting. A lot of the time is triggered by a viral infection of your upper respiratory tract. The symptoms can last for about around 1 week. And most of the time, the patient will get better without antibiotics, regardless whether it's a bacteria or virus as the source. I'm going to introduce 2 clinical decision tools here when you deal with acute sore throat. And I think this is very important, especially when in clinics when you're busy or you're trying to decide very rapidly what you're going to do with this patient. So the first criteria that I'm going to introduce is a fever pain criteria. So basically, every criteria you're going to score 1 point. A maximum of 5 points, which is 5 criteria. So the fever is the first criteria. So in the first previous 24 hours, if the patient comes to you with fever, they said they had fever in the last 24 hours, you put at 1 point. have a look at the tonsils. If they have purulence or pus on the tonsil, you can give another point. If they come to you within 3 days of having the onset of symptoms, it tells you that there's something really maybe sinister going on. So give another point for that. Look at the inflamed. Is there severely inflamed tonsils, grade 3, grade 4, grade 3 tonsils? Then probably give another point. And they have no cough or coryza symptoms, inflammation of the mucous membranes in the nose, right? So you give 1 point for each of them. So the higher score suggests that you're more likely to develop a bacterial source for your sore throat. And so what the fever pain criteria, the authors of it, basically puts a likelihood of you isolating streptococcus when you do a nasal, a throat swab on them. And basically around 20%, you're going to isolate streptococcus. In the middle, about 2 or 3 points, you're going to isolate about 40%. And 4 and 5, which is the severe part, it's only about 60% chance of you isolating streptococcus. The other criteria that I'm going to introduce is basically called a Santor criteria. So you can use either one, a fever pain criteria, or you can use a Santor criteria to decide when you're dealing with a sore throat. And basically, the Santor criteria looks at 4 criteria, looking at a tonsillar exudate, whether you have anterior cervical lymphadenopathy, which is tender, you have a history of fever, and you have no cough. So it's very important here that no cough is a very common criteria here in the fever pain in the Santor. Right? Okay. So in the Santor criteria, if you have a 0 to 2, again, it's almost about the same, about 17%, roughly around 20% chances you're developing streptococcus. And again, if you're in higher score, you're about 56, which is about the 60% mark as well with the fever pain criteria of isolating streptococcus. So how are you going to decide then? So you've seen a patient with sore throat. You classify them using the criteria that's been outlined here. So how is that going to help you to decide what to do with these patients? Now, if you're using fever pain or Santor and your score is 0 to 1 or 0 to 2, do not offer antibiotic prescription. As I said earlier in my slides, that majority of your sore throat will get better after 1 week, irrespective whether it's a bacteria or viral source for your sore throat. Okay, but again, there is always the caveat: if the patient develops worsening or rapidly significant symptoms, do not improve after 1 week, or they become systemically very unwell, always come and seek emergency medical help. Right? Okay. So the criteria can help you to decide, but they are not foolproof. Right? Now, fever pain has got a score in the middle, which is 2 or 3. If you notice, the Santor criteria do not have a center middle ground. But if you use a fever pain, you do have a center middle ground between offering no antibiotic and offering antibiotic. So again, if you use a fever pain and you develop a middle ground between the score of 2 and 3, you can consider not giving antibiotics. However, there are a caveat. They say that if you may consider giving them a backup prescription if they do not improve within 3 to 5 days, or if they worsen rapidly or significantly at time. And this is something that sometimes we do practice, even in my practice with COPD patients, that we give them a backup supply of prednisolone in case they do have an exacerbations attack. And it has to be individualized. When you see a patient, you have to decide then, are they going to be able to understand and comprehend using a backup prescription whenever they need it. Right? Always make sure that you also explain to them about the possible adverse effects of antibiotics, particularly about diarrhea and nausea. Okay. And lastly, which is the severe pain. The severe criteria, which is the fever pain score of 4 or 5, or the Santor score of 3 or 4. Okay. And if you have a patient that scores highly on this criteria, consider immediately giving an antibiotic prescription. If they look unwell to you at any point when you see them and you score them, think of severe systemic infection, refer them to the hospital immediately. Look for, they may be having peritonsillar abscess or Lemierre syndrome. You have your pharyngeal abscesses, retropharyngeal abscesses, and they can get very ill very, very fast and deteriorate. Okay? So I've introduced 2 criteria. I hope which can help in your practice when you see somebody with sore throat. And the last major area that we're going to be talking about, what you're going to see in your practice most likely will be acute rhinosinusitis or sinusitis. And again, so these acute sinusitis usually follows a common cold. So these are patients who came to you with acute cough initially. They got better, but more than 1 week later, they come in with acute sinusitis. So basically, these are basically something most commonly associated with common cold rather than a viral or bacterial acute sinusitis. A patient with acute sinusitis normally will present with nasal blockage or congestion. They got nasal discharge. Some of them may have dental or facial pain where you have your sinus pain there. And again, because it involves your nasal areas, you may have a loss of sense of smell. So obviously, if this a patient comes into you and say, I can't smell, the first thing you'll think about is COVID first. Do a swab, that's negative. Then okay, let's think about sinusitis after that. A little, very short things about acute rhinosinusitis is usually self-limiting. Most commonly is due to a viral infection for a common cold. Very, very few. 2% only of your cases will be due to complicated with bacterial infection. And the thing to remember is they can last longer, about 2 weeks to 4 weeks. And they will get better. Again, just like as in sore throat, they will get better without treatment, irrespective of whether it's a bacteria or virus. And the complication of acute sinusitis is very, very rare. You're looking about very few, 2.5 to 4 per million of per people per year. Okay. Even if you withhold antibiotics in patients with acute sinusitis, it's unlikely to lead to complication because of the rare complication rates. But however, there's always something you need to think about. Am I dealing with a bacterial infection and the patient is not getting any better? So a patient comes to you, they got symptoms of more than 10 days, think that they may have a superadded bacterial infection or bacterial cause which is not resolving. If they complain to you, they've got a discolored, purulent, foul-smelling nasal discharge. If they have severe localized unilateral pain, particular pain over your teeth and your jaw, where your sinus are. They have fever. So these are fever that has lasted more than 10 days. You need to be very careful that they may have a bacterial cause for it. And they have a marked deterioration after an initial milder pace. So patient who may have come in with common cold symptoms comes to see you with acute cough, not so much of a fever. You may give them some symptomatic relief. 10, 11 days later, they come back to you saying, I'm not getting better. I'm still having fever. My nose symptoms are getting worse. I can't breathe. The discharge are getting worse. So think about they may have a bacterial superadded infection. And this is from Matthew Elphalagas, which actually look at the meta-analysis of how the RCT is looking. So this is how they come up with the idea that 10 days is the limit that you're going to wait in somebody with acute sinusitis. So at 10 days or more, if there's no improvement, you may consider prescribing a high-dose nasal corticosteroid for 14 days for adult patients. But the funny thing is what they found from the meta-analysis that there's no major difference in clinical effectiveness between all the classes. And also there was no significant difference in the cure or improvement rate between giving an antibiotics of only 3 to 7 days, or you give them a bit longer between 6 to 10 days. Right? So what I normally do is I just give them 5 days of antibiotics. I very rarely give them up to 14 days of antibiotics, depending on how severe it is. But majority of my cases, I give only up to 5 days of antibiotics. And I believe that is my last slide. Thank you very much for listening, and obviously stay safe, everyone.
Thank you, Dr. Arfian, for that very informative talk. Dr. Arfian now will address the question. There are no questions yet at the moment, I can see, but we'll give them a bit of time to write the question. In the meantime, I'll start with one question. Yeah, what do you think about this practice of giving prophylactic antibiotic to URTI cases, even when the pain score or the symptom score doesn't actually warrant for them to give antibiotic at that particular moment, especially with chronic cases. I mean, chronic patient who's having diabetes or any other concomitant illness which might predispose them being immunocompromised.
Okay. Yeah, thanks, Eugene. That's a good question. I think what the the fever pain criteria gave is the middle ground where you do have a backup prescription. Um, Now, obviously, when you do see a patient, you need to classify them as having a high risk of developing, progressing into more severe disease or not. So what the fever pain criteria does is that when you score lowly, the risk of you progressing is low. So in that case, what they actually advise is do not give antibiotics. However, obviously the caveat is that you always tell them that if they do deteriorate, which is there may be a small proportion of patients who do deteriorate, then they should come back and see you earlier. In the middle group, where you have this middle ground, then you can give them a backup prescription. Give them symptomatic relief. If they're not getting better after 48 hours, they may take the backup prescription to start taking antibiotics. Okay. That's how I practice it. Now, if I think patients who have diabetes and other chronic immunosuppressed condition, as in my slides as well, they're more likely to develop upper respiratory tract infection. Now, are they going to develop a super added bacterial infection which may progress? I think if you look at my slide as well, majority of your acute cough, your sore throat, irrespective whether it was a bacterial or viral infection, they're going to get better. So majority of them are going to get better. There's only very few that are going to deteriorate severely. So I think that the main thing is you need to follow them up closely. Yeah. I think I didn't put up here, but there was a paper published in Malaysia which looked at antibiotic prescribing in primary care. It was published in the Australian General Practice Journal. We actually found that majority of antibiotic prescription, overwhelmingly about 60 to 70%, were prescribed for viral causes, things that if based on the following criteria were not indicated. But I think it's easier said than done. I mean, I fell into the trap as well. Sometimes, patients are very insistent. They go, no, I want antibiotic. And then sometimes you say, I'm not going to argue. Okay, I'll give it to you. Yeah, I understand what yeah, there's a fine line between what's doing right and practicing as well.
All right, thank you, Dr. Arfian, for that clarification. I think we have a few questions there. Maybe Dr. Arfian can read them and answer them straight away.
Okay.
From Amirul.
Amirul, okay. Is center criteria the same as Mengasa to decide whether to give antibiotics? Not that I know of. I think the center criteria is from a different author. I can't remember the name of the author as being in the McISAC. So no, I don't think it's the same. I may be wrong, but if I remember correctly, the center criteria of the author was not McISAC. Is it useful to give Thymol or betadine gargle for sore throat? Okay. Thymol is more of a, if I'm not mistaken, is a local anesthetic, isn't it? Yeah. It hasn't got any antiseptic properties. Now again, symptomatic relief, probably it does help. In terms of betadine gargle, yes, I know. I've read the studies that look at betadine gargle for sore throat. If I can't remember the name of the author who did that study, but I think what they did was that they did found that there was a clinically significant in terms of symptom scores, but in terms of the recovery rate and everything, it was no difference. What is the best treatment for cough in less than 2 years old? Oh dear. This is a pediatric question. I'm afraid I don't see pediatric patients. I wouldn't be the best person to answer for that question. Maybe Reason will be the best one to answer for that.
I won't be the authority to answer that question as well, but it is a major dilemma for us GP because we see a lot of patients under 2 years old and almost all the cough and cold prescription are not actually allowed to be given for children under 2 years old. So this question, I have my own practice. How do I do it lah? But of course, I'm obviously not the right person to say it here also. But we will have a pediatric to come and give us CME later on in the future. So probably we can reserve that question for that particular person in the future.
Okay. Nice
The
reason.
next question.
Uh, is lysozyme indicated for tonsillitis or URTI? Um, this lysozyme is more of an enzyme which actually breaks up the mucus and helps you clear it up. No, tonsillitis is more of inflammation of your tonsils. URTI, if you have associated laryngitis, it may help reduce the inflammation. But again, I think it's more of symptom relief. I'm not too sure whether it does make any difference in terms of your recovery rates for tonsillitis or URTI. I don't use lysozyme in my practice, but I guess so I don't have much experience using lysozyme. If patient is very insisting, but Dr. Shaw not severe UTI, can we just lower dose? Oh, uh, I think the main thing we have to keep an eye on is antimicrobial stewardship. So I think if a patient is very insisting, but you're not sure it's a severe URTI, you can counsel them and give them a backup prescription. Basically, when you're not sure it's a severe URTI, you're in two minds. Basically, is this patient going to go into severe or is he in the midline, isn't it? So instead of giving a lower dose antibiotic, which is you're going to cause resistance and inadequately treat the infection, you might as well counsel him properly and give him a backup prescription. So that if he doesn't improve, then he will go on a full dose of antibiotics for his infection. Best natural remedy for sinus. Oh dear. Uh, the the one I use is metal vapor, which our pharmacy prepare, and basically they put in hot water in the bucket, and they put a towel over their head, and they inhale the metal vapor. So our pharmacy prepares this metal crystal for them to use. That's the one I use. Metal and eucalyptus has been known as a traditional complementary medicine to help with sinus symptoms. So that's what I use. I basically use metal crystal. Natural remedy for common cough is honey. Yes, that I have. Yes, I agree. It has been proven in studies that honey do help with common cough. And actually, if you look at the NICE guideline in 2019, which is included in my slides, they do have a section on traditional treatment for common cough and URTIs, and honey do have some evidence for it, but unfortunately not so much of any other traditional complements there. Okay, next question. Is it beneficial to give oral? Acute cough, if it's due to asthma, then you will treat them with a bronchodilator. Now, obviously, as a respiratory physician, we do try to avoid oral medication because of the systemic bypass and the systemic side effect that you get from it. So whenever possible, we do advise to give inhalers. Only in severe cases do you give oral salbutamol in terms like patient cannot use inhalers, or you're dealing with, I guess, kids. I think most of them will get kids. But I do understand that there are some patients who do insist that they do not like inhalers. They just want oral medication, and I think um, it's not common practice, but it's not also wrong to give. So I guess you have to tailor it to individual patients. Any long-term effect of constant intake of antihistamine? I think you there's no strict rule when you think about long-term use of medicines. It's always about risk and benefit. Um, so I know that some patients with persistent nasal symptoms, they do take long-term antihistamines. I have patients who have spontaneous chronic urticaria under my follow-up. who take long-term antihistamine. So when it's indicated, I guess it's you have to give it, but obviously you always have to weigh the risk and benefit of long-term medication. Right. Is prednisolone any benefit in acute tonsillitis to reduce the inflammation? Now, okay. I can't remember the name of that study. Again, in prednisolone, we're talking about adults, right? I know some practice, some institution, they do practice giving prednisolone to reduce inflammation in pediatrics. But in the adult population, it has not shown to be any difference in terms of recovery rates. Helps to reduce cough or sinus, cold. The recommendation for vitamin C when you have an infection, especially a URTI, is basically high dose vitamin C. And the recommendation of that dose is between 500 to 1000 milligram. And you take that for not more than 10 days. They actually advise that you take it as the shortest period possible as soon as your symptoms starts to recover. So there is evidence that it does reduce the symptom duration, but nothing else.
All right. Thank you again, Dr. Arfian. Look like the question has stopped for now. Let me check my WhatsApp if I've got any questions from my WhatsApp. All right, no, we don't. Okay.
It's good to have so many questions on the Sunday during dinner time.
Okay. Okay, if there are no more questions from the participants, again, I would like to thank Dr. Arfian for giving us this time and opportunity to teach us about URTI. And thank you all for you guys who are at home and participating in this teaching session. Now, we're gonna show you the QR code, and please scan the QR code for your CPD point. Or if you have problem scanning them, please register your name as soon as possible after this talk. We have given you the link to register earlier on. Please register your name if you have problem getting a point after you scan the QR code. Thank you to our secretariat, Ms. Melissa and Mr. Adrian, for their assistance. Thank you to all sponsors, Gleneagles Hospital, Kota Kinabalu, and BU Medical. We will see you again in 2 weeks' time. Thank you.
Nice. Thank you for having me.